Yes, we can
I
hear
can
you.
hear you, Rain. There's a bit of a lag.
Oh,
Yeah,
folks,
okay.
listen, we do the show, we make it happen. The show must go on. Look, I see all the heart emojis. Everybody's ready to go now. Let's get some questions from the audience.
All right. I'd love to be able to hear them.
Yeah, I know. I'll read them to you. I'll make sure that I read them to you. So everybody go ahead and start sending in your questions. We're going to get to them now. Now that we have the doctor, now that we have the good audio, we're going to have a great episode today. Dr. Halperin, before we get started, I know that you mentioned how many of your patients and how often you work with this disease. I always like to kind of go back to the beginning. Do you remember the first time you dealt with a patient with this disease? Can you recall a singular story?
It's interesting. I mean, I do still sort of, distinctly remember the first time I encountered a neuroendocrine tumor patient in the hospital back when I was a resident. Like I said, it goes back kind of a while. And it was a woman who, was sort of hospitalized dealing with yet another bowel obstruction, as we see so commonly. And I just remember, her oncologist, who's Dr. Kulke, some of you may know, and sort of the time and attention that he paid during the hospitalization, and just sort of her incredible resilience in the face of sort of obstacle after obstacle after obstacle, and how it was very much not her first rodeo. That was actually very much the experience that sort of prompted that first conversation with Dr. Kulke about sort of getting more involved, and really coming to grips with how much the folks in this field are in need of our help. Just an incredible woman.
What were some of the challenges that you faced then? Like some of the things that were really making it difficult to do your job in the early days?
Well, I mean, to be fair, I mean, my job in those days was as the house officer, so I was mainly just responsible for keeping the electrolytes and the fluids balanced, which was not that hard. I think that the challenge, though, of the situation, right, is just that, as you know, I mean, often we're dealing with problems that don't have great solutions, and sort of dealing with sort of the fine balancing act of how you maintain someone's quality of life, even if you can't fix the problem, and try and help keep them out of the hospital. And like I said, fortunately, at that stage of my life, I didn't have to sort of, I don't think I knew enough to understand quite what those challenges were, but I sort of can recognize now in hindsight just how difficult it was. Actually, you remind me. So that's an accidental lie. So I will tell you the first patient I encountered. It was as a first-year medical student, and I'll tell you a funny story. So I was at Cornell, and so I was actually my very first clinical exposure. I've forgotten this, but my very first clinical exposure was in the GI oncology clinic at Memorial Sloan Kettering. And I actually, this was so long ago, I don't remember many of the details except two things. One, the attending really wanted to drive in the teaching point about this patient with carcinoid syndrome. And at the time, he said we don't let them go to the OR without the vial of octreotide at the foot of the bed to protect them from carcinoid crisis in the operating room. And two, as it turns out, I repress this memory sometimes, but it turns out that actually my very first homework assignment as a first-year medical student was to explain the mechanism of action of octreotide. It's actually completely true. The attending wanted to correct me. I'm actually pretty sure I was right, and he was a little bit turned around to this day. But that was actually my very first exposure, was all those years ago. You remind me now. I couldn't tell you anything else what was going on because I really didn't. I barely knew where the bathroom was in the hospital at the time. But I hear they have an app for that now. But that was actually, now that you asked, the very first time I ran into a neuroendocrine tumor patient.
Gotcha. Well, Dr. Halperin, we've already got a lot of questions rolling in, and
wonderful.
Started a little late. I'm going to go ahead and pivot. I mean, I'm interested in this. I can ask you questions all day, but we're not here for me. So let's go ahead and start taking some questions from the audience. So Amber says, what's your opinion on treatment overall for a net of the appendix? And so I know that's kind of a broad question, but are there unique things that, approaches that you might take specifically for a net in the appendix, unique problems it presents? What are your thoughts there?
It's a good question, and I think it sort of depends on sort of the phase of the illness and kind of where you are in the big picture. I think that we know enough to understand that appendiceal neuroendocrine tumors are probably fundamentally different from many of the neuroendocrine tumors that we encounter in clinical practice routinely. I think where a lot of the questions that I encounter come up is really around surgery in sort of that initial setting. And, the question of, should you be doing a more aggressive surgery in an attempt at cure? And in fact, do we know that doing a more aggressive surgery is increasing your odds of cure in those settings? And I think that, this is one of those areas where I think our current thinking is we actually tend to lean a bit more aggressive and lean towards doing, what we think of as definitive oncologic surgeries with, lymph node resections and so forth, without honestly really knowing if taking out those lymph nodes is curing anyone of their cancer, even if we know there's cancer there, because the biology of the disease is so unique and fortunately in many cases, even more indolent than we see for other tumors. So that's, I don't mean to paint too broad a brush. I've certainly been in positions with patients where our backs have been against the wall with appendiceal neuroendocrine tumors. I don't want to pretend that it doesn't misbehave ever. But for the vast majority of people, I feel like the main question is, when are we doing too much versus too little?
No, that's a great point. Thanks, Amber, for your question. Hopefully that helps a little bit.
Yeah.
Next question from Dave. What would be your recommended treatment when my current treatment of lanreotide stops working? I've been on lanreotide for 3 years.
Yeah. Obviously, it would be hard to sort of make a specific recommendation. It depends a lot on the circumstances. I will tell you the way I think about it in case it's helpful. Usually I say as an oncologist, I'm only smart enough to ask really, 2 questions at one time. One of them is there a lot of cancer or a little? And the other is it getting bigger or not? Obviously, this is sort of predicated on understanding, grade stage primary sites for those underlying details, but in terms of what's changing in front of you. And so then, we tend to think about, are these situations where we think there's a reason to be doing some sort of local or local regional therapy like surgery or interventional radiology approaches, say if there's one spot that's growing or a focus that we're really worried about, or more systemic treatments. And then it sort of becomes, are we worried about more aggressive disease and thinking more PRRT, or is this more of a slow, sluggish progression and we're thinking more targeted therapy, everolimus or sunitinib if it's a pancreatic net, that sort of thing. Too many variables to get into, but that's at least kind of my high level framework in 30 seconds or less.
Perfect. Thanks, Dave. Hope that helps. So Linda and a few others are curious, and actually this question has come up before. I'll give you a quick little background. My son, Linda says, my son had a 2.4 centimeter neuroendocrine tumor of the appendix removed a year and a half ago, at age 27, so he's young. He just had a negative CT scan, and the plan is to do CT scans to monitor him for the next 15 years. I'm concerned about the amount of radiation he will receive at such a young age. Would NET test and MRIs be reasonable monitoring for the future? So, there's a couple questions there, but I think the main thing is that concern of radiation for, at the young age or really any age. But I know a lot of patients are concerned about that.
Yeah, and great question. I wasn't anticipating the appendix quiz today, but I think it's it is a great broad question. I think there's a couple things to think about. One is, I do think in these sorts of situations, one is it can be reasonable to sort of vary the kind of imaging you're using to reduce the radiation burden. So I agree, in younger folks, thinking about using MRIs where appropriate is reasonable. Depending on the site, meaning the cancer center that you're using, and the way that they do their scans, some places have a harder time looking at the lining of the belly and the lymph nodes that drain the terminal ileum and appendix, right? And those are kind of two of the major things that you're thinking about when you're doing that restaging. So, I mean, I wouldn't necessarily do only MRIs forever in that kind of situation, but I do think that using them to try and limit the radiation exposure is a good idea. The other thing I'll point out is that actually we have been tweaking the guidelines around surveillance over the last couple of years. And so if you look at, or if the oncologist looks at the NCCN, which is kind of, we think of it as one of the gold standards for clinical management, we do start to think about doing scans every other year for folks for tumors that arise outside the pancreas in the surveillance setting. And so I would say that, especially, and I wouldn't pretend to get into the details of someone's case and making a specific recommendation, but thinking about that question of A, can we change up what kind of imaging we're doing? And B, can we think about spacing it out to every other year, in at least for, part or all of that, I think would be questions I would have. And I do think, you do bring up a very, and there are other tests I think that are out there. There's a lot of different sort of blood tests that people send. I wouldn't pretend to, render a specific opinion on any of them, other than to say that really, the backbone of surveillance is imaging, and that really, I think, is what you'll find in sort of most of the guidelines, is that the backbone of surveillance is imaging, in no small part because that's what determines what you will do, is knowing what's on the scan.
Absolutely. Thanks, Linda. Hope that helps.
Great question.
Yeah. Totally. Next question from Jim. Jim says, when chromogranin goes up, what numbers are considered? 650 going to 750 EG, or does it take the thousands to begin to worry?
So also a very good question that actually follows on perfectly from my saying there's lots of blood tests that people send. It's almost like Rain does this really often, picking the questions. So, chromogranin has a very long history in the neuroendocrine field. And, I think that, and I should make a full disclosure, which is that I'm actually helping to run a study right now trying to understand the utility of chromogranin in a controlled setting for patients in collaboration with the company that makes the test. So, just in the interest of sort of full disclosure of any potential conflict, I do just want to say that.
Really good.
That being said, even though I have research funding from the company that sponsors the test, in standard clinical practice right now, it's extremely difficult to interpret sort of numbers in a vacuum for a given person. And to be honest, in my practice, even though I do still send it routinely, there is no specific magnitude of change that makes me reach a specific conclusion absent other data. As I actually was just saying about surveillance, really the imaging is still what drives the management for us. And for that reason, there are many folks, I'm not one of them, but I completely understand their position. There are many folks who do this all day, every day, who actually decline to send the chromogranin because they find that it tends to lead them, it runs the risk of leading them on a wild goose chase. So I hope to have more data about that over the next few years that will allow us to use it in a very sort of informed and thoughtful way in the right patient at the right time. But right now, no specific threshold, at least in my book.
Got it. Thanks for your question, Jim. Moving on.
Great question.
Yeah. I mean, this crew is they know their stuff. They know their stuff.
That's why we love doing this.
Absolutely. I love this community for that reason. So Dorothy, and it seems like a lot of other people, has a question. Is there a definitive way, or is there a way to definitively determine if a patient has carcinoid syndrome or not? my team is divided in their opinions on this. And also, does it matter? Do we need to know for some reason? So if I'm not sure if she, the kinds of symptoms she's having, but like, is there a point where it's like, yes, you absolutely have carcinoid syndrome, or no, you don't? And where is that line? How do you know?
Yeah, it's a really good question. I mean, I think that I think many of us are used to thinking about sort of the ends of the spectrum, right? This person has a sky high 24-year on 5-HIAA, and they have right heart valvular dysfunction and they're flushing 20 times a day, and I put them on a somatostatin analog and it gets better. That person has carcinoid syndrome, right? The person who you don't even bother to send the 5-HIAA because they have absolutely no symptoms and everything's fine, that's obviously the issue is, right? No test is perfect, right? I wish I had a better answer than that. There's definitely a gray zone of folks where it's never quite totally clear. And the truth is, it does matter. And sometimes it can be a bit of an academic point, right? I mean, I think that in my practice, and I think many of the folks who I work with, we tend to deploy long-term somatostatin analog therapy to suppress the carcinoid syndrome in folks where we believe that it's there, right? Because we think that by suppressing the serotonin secretion, we're protecting the valves of the heart. And by the way, making the person feel better in the meantime seems like a good thing to do. The challenge, though, right, as well, what happens if you're not sure? Do you leave them on this therapy, which has non-trivial, I mean, it has a cost and it has, some side effect burden, even though both we hope are modest for most folks. And what if you're not getting the benefit that you want out of it? That becomes a really sort of dicey situation. And I wish I had a better answer. I wish I could say, yes, definitively, it is or it isn't, and you should or shouldn't be on X or Y. But I know that it's very real. I do think there's one thing I would say, which is one of the first things I learned from Dr. Kolke years and years ago, is it is really hard to have carcinoid syndrome without a carcinoid tumor. And the situation, I think, where this becomes, sort of towards that easier end of the spectrum, if you will, is there's definitely folks who have symptoms for lots of reasons that can sometimes lead us to think that they might have carcinoid syndrome. But if you can't find the tumor anywhere, it's at least fairly unlikely that that's what's going on. I don't believe in absolutes, but that's sort of the one situation I would think of where, I would nudge people in that direction. Otherwise, you're right, completely difficult gray zone.
Yeah, absolutely. Next question from Ruth. If after 4 treatments of PRRT, what percentage of patients do you see improvements with? Are you able to put a number to that? Like, I mean, I know that's like after the cycle of PRRT, like it help everybody? Does it help us, 50% of people?
Sorry, with respect to tumor control or syndrome, or what are we thinking about? Or do we not have specificity?
I think that's tumor control, but I lost the question. But if you're out there, you can chime.
Yeah, I mean, so it's a great point. I mean, we have really great prospective data in sort of mid-gut neuroendocrine tumors, right? I mean, we know that sort of point over point, there's that 80% reduction in the risk of progression or death, right? So we know that sort of the vast majority of folks are deriving some benefit with respect to tumor control. And shrinkage, we know, again, with mid-gut is less common, maybe somewhere in that 15 to 20% range with a couple percent margin of error in there. We don't have great prospective randomized data for tumors that arise outside the midgut, right? So, do I think it's pretty similar in those folks in terms of tumor control? Yeah, I think it's pretty similar, based on what we see in terms of retrospective data and clinical gestalt, but I wouldn't pretend to be able to put a precise number on it. Shrinkage we know is higher, say in the pancreas. How much higher, I can't tell you with the data that we have, but it is higher. And syndrome control is real. There are not just there's quality of life data, that quality of life is maintained from NETTER1, but there also, if you go digging, I mean, there are data about sort of diarrhea control in patients with carcinoid syndrome going back sort of before NETTER1 was a thing. So it's real, and I think many folks will benefit in at least one of those three ways. But there certainly is that smaller fraction of folks who do not, and that's a difficult problem to face down.
Got it. Thanks. So next question from Sherry. Sherry says, how often should an echocardiogram be done?
Oh, that's a really good question. So I believe the cardiologist will tell you once every year or two. I think that's kind of what the cardiology guidance is. I will also tell you in clinical practice that may or may not be what everyone does. In my practice, I tend not to lean on them as frequently, frankly, because the echocardiogram doesn't define whether the cardiologist will intervene or the cardiac surgeons. The symptoms drive intervention. So I often, especially for folks who are traveling and their schedules get kind of packed with tests and things when they're coming to see us, I have a hard time asking them to go through one more test and take on the time and expense and inconvenience of that. When I know that if they're feeling well, I won't do anything with the result. That always kind of, I have a hard time doing things that aren't going to change what we're going to do. So I would view that kind of flexibly, but I believe that's actually the official guidance. Please correct me if I'm wrong, anyone.
Got it.
And by the way, that's in folks with active syndrome, not just anyone with any neuroendocrine tumor of any kind, I should say.
Thank you. From Nalia, is high blood pressure possibly driven by NETs? Is that a common symptom?
So this depends a bit on subtype and so forth. I would say I have had a hard time ascribing hypertension to a classical neuroendocrine tumor, high blood pressure to a classical neuroendocrine tumor. Pheochromocytomas and paragangliomas, which you know are neuroendocrine neoplasms, those, yes, absolutely, that's part of the syndrome, kind of a different animal. But say your classic small bowel carcinoid tumor, I tend to see that less commonly. When they make things, right, and they make serotonin, that actually has what we call a vasodilatory effect. So it makes the pipes bigger and which actually kind of lowers the blood pressure. We do see it with some of our therapies, especially VEGF therapies. But I actually believe there has been some suggestion that sometimes when you control the syndrome, the blood pressure goes up because the blood vessels will firm up and tighten up, and the pressure goes up. But I don't believe it's particularly common with a conventional neuroendocrine tumor. Long answer to a short question. Sorry.
No worries. Welcome everybody. If you joined us late or have joined us recently, we're here. This is Luncheon with the Experts. We are here with Dr. Dan Halperin, who ran barefoot 2 miles up a mountain to get here and made it just in time through the storms of Texas. So we still have 30 minutes left. Go ahead and get your questions in. And if you know anybody else, our numbers are looking great. If you know anyone else that would benefit from the show, tag them in the comments, share the video to their Facebook page, let them know that this is going on. But also, if you want to refer back to the video or send it to someone later, it will live right here on the Facebook page under the videos tab. And starting Monday, we republish it to the Carcinoid Cancer Foundation's YouTube channel for those that don't have Facebook. And as always, I want to continue to reiterate that if you don't get your question answered or you have a follow-up question, don't hesitate to reach out to CCF here on the Facebook page or at carcinoid.org. Okay, moving on. Still got a lot of questions. This is interesting. I'm not sure of this trial, but Linda says, can you discuss the current trial involving chemoembolization of carcinoids in the liver? Is there one?
So that's a little broad. I know of I wouldn't ever pretend to know of every study on the face of the planet. There is, Dr. Sulin from Penn is running a randomized study called RETNET of sort of chemo versus bland embolization, trying to understand way whether one is better or they're truly the same. There's some, I had heard of a study at UCSF that I think was actually radioembolization, selective insulin radiotherapy, so not truly embolic with immunotherapy. But beyond that, I'd have a hard time sort of getting too specific. I'm sorry.
Gotcha. Oh, I saw that. I heard that. a good resource for patients. Still hear me okay?
Sorry.
You want off your Bluetooth maybe?
I'll switch it back in case it's mine.
Hello.
How's that?
Yeah, great.
Oh, sorry. Is there a question that I missed with the audio?
Oh, this audience, as you can tell, has lots of questions. So we'll just keep churning along. Okay, so next question from Sonia. What may cause carcinoid crisis, and how would I detect the difference between an adrenal and a carcinoid crisis?
Oh, so it's a great question, and so they are two sort of different things, right? I mean, so
find them both first,
yeah. So I mean, a carcinoid crisis we tend to think of as an acute surge in particularly vasoactive hormones, generally from a small bowel neuroendocrine tumor, that usually causes an acute drop in blood pressure. And an adrenal crisis is a little bit different. That's folks who, for one reason or the other, don't have functional adrenal glands. And then typically, at least where I've encountered it, that's in the setting of they get sick for some other reason, and then they can't pump out the sort of blood pressure supporting, catecholamines, adrenaline, and so forth to support themselves through the illness. Fortunately, the frequency with which folks with secretory neuroendocrine tumors go to the adrenal glands and knock them out, or go to the adrenal glands and prompt them to be removed, that's a pretty small group. I tend to see adrenal metastases more from lungs or foregut neuroendocrine tumors, where we tend to see a bit less serotonin, not none, but less. So it's a pretty rare on rare situation to have lost both adrenal glands and have carcinoid syndrome. That being said, I think that generally we tend to see carcinoid crisis in the setting of some sort of acute shock, right? So we think about surgery being classic. They make the skin insertion, the pressure drops. Fortunately for everyone involved, I don't spend any time in the OR. Really, nobody would want me there. So I fortunately haven't actually seen that face to face, other than, like I said, that very first patient that don't go to the OR without the vial of octreotide still holds true. The other situation where it's actually fairly common in relation to the last question, in the IR suite, right? So as you're acutely embolizing a tumor, sometimes you will see a hormone surge, and I've certainly had that happen to folks over the years. Adrenal crisis, like I said, usually we tend to see that in the situation where someone gets sick with something else. They get a pneumonia these days, or something else happens that makes them sick, and then they just sort of feel really bad. And usually that's sort of outpatient versus inpatient, and the person comes to the hospital. But I don't know if I've adequately addressed it. It's a pretty rare on rare question, I think. Good one.
What we try to do here on the show is just give good general information and knowledge that helps get people to the next step. I think you 100% did that. Absolutely. Aaron says, do you recommend advanced micronutrient blood testing? Oh, I just lost that question. There's so many questions today that it keeps shooting them. I can't see the older ones. Judith asked, have you heard that you should have chromogranin test after fasting? A couple people had that question as well.
Oh, so let me think about that for a sec. What I would say is this. Do you need to do it after fasting? No. Is it probably going to be more reproducible if you do? Yes. But again, what I would actually prefer to emphasize right now is that right now, I think in routine clinical practice, the precision of that test is not I wouldn't put it at the level where you fasting is going to be the thing that changes the way that the test gets it. It should get interpreted and affect your management, because I think there's currently in routine practice just sort of too much variability there to really worry about. So don't drive yourself nuts and make yourself hypoglycemic trying to get a fasting pomegranate.
Mm-hmm.
That being said, sorry, there's one more thing I should say on that, which is actually technically at this moment, the way that test is done, again, I know this because of my existing conflict of interest investigating right on the study, it's actually technically a lab developed test. So, so what that means is every single place that's doing it is at least in theory doing it its own way, which means that specific lab may have specific requests that they make of you in order to sort of maintain that sort of quality control that they have in their lab for the conduct of the test. So don't go against whatever the lab is telling you to do, which may be why there's some variability out there now that I think about it. You can tell I'm thinking in real time. But I would say, do I believe biochemically you need to be fasting for it as a general rule? Probably not.
No, I think that clarification was important. No, I appreciate you including that. Kathy says, can other tumor products like histamine also cause heart damage, or is it only in specific serotonin?
So what I will say, I always have a hard time answering a question of can something ever happen. However, what I will say is if you go back to the original studies of carcinoid heart disease in the cardiology journals, they did actually very nicely and specifically associate serotonin loads sort of in blood, in platelets, and in urine. I think they did, if I recall, I know it was on platelets as well as at least one sort of straight biochemical measure. Those were very tightly associated with carcinoid heart disease. So the best evidence we have is serotonin. I would never pretend that I could say definitively 100% either direction, but I don't think there's as strong a known linkage with anything else.
Got it. Thank you. And thanks for your question, Kathy. Anna says, what's the difference between Y90 and immobilization? I'm confused.
Great question. So, so at a high level, right, the theory behind the interventions is, it goes back to actually these old animal experiments in the 1950s. So tumors that are in the liver get their blood supply primarily from the artery. They draw arterial oxygen-rich blood supply, as you might expect. The vast majority of the liver is drawing the majority of its blood supply actually from the portal vein that's draining your gut. So if you put stuff into the arteries, they will preferentially attack tumors just because the blood supply is primarily arterial, right? So you can do a couple of things with that. One is you could just block the artery, right? And if you block the artery, the things that are dependent on the arterial blood supply should die. That's the theory behind bland embolization and chemoembolization. What Y90 is generally doing is they're using, and the technical stuff is honestly beyond me, I'm not my RDoc, but they say they use these smaller glass microspheres that aren't embolic. So they're not choking off the blood supply, they're just taking advantage of the fact that because the tumor is enriched with the arteries, it's going to concentrate the dose of treatment at the tumor. And then what it's doing is radiating the cancer and killing it with those yttrium-90. That's the radioactive particle that's on the glass bead. Functionally, what does that actually mean for someone? Couple things. One, at least in our practice, and I won't pretend to know what's done everywhere in the universe, but generally speaking, folks who we do embolotherapy, meaning bland or chemoembolization, those folks usually acutely, right, you're choking off the blood supply of something. So folks can feel a little bit sicker, a little more pain. Those folks often will stay in the hospital for some period of time, whether it's extended recovery or a true admission, in order to control that acute phase of pain, because that can be sort of more of an acute issue. Whereas the Y90, that sort of cell kill, we say actually takes longer and is a little gentler. But there are some literature to suggest that maybe there are long-term radiation side effects. So it's a delicate risk-benefit balance between the two. What I have learned from some of the interventional folks is there are certain situations where we worry more about depriving parts of your liver of blood supply, even to a modest degree. The most important one to know is after your biliary tree has been, as we say, violated, meaning folks who've had a Whipple, so they've lost the head of their pancreas to resect a pancreatic neuroendocrine tumor, or folks who've had other interventions on the biliary tree that allows the gut bacteria to work their way up. And then we say it's never sterile again. So if you go and embolize, there's a risk. And in the retrospective series, the risk is there with these embolic therapies. There's a whatever it is, 10, 20% risk, I think, forgive me if I misstate, that you'll get an abscess after you combine those things, an embolotherapy that follows violating the biliary tree. The yttrium-90, at least the retrospective data suggests that the rate is lower. Again, hard to compare retrospective data, but that's kind of the thinking. And in practice, people tend to lean more on those non-embolic radiotherapies in the setting of folks who don't have a sterile biliary tree. In many centers, I won't pretend to know all.
Got it. Thanks for your question.
Sorry, long answer for a question.
Thorough, Dr. Halperin. That is a good thing, my friend. But you make me, when you touched on the Whipple for a moment, I just wanted to announce to everybody out there, we've been doing this in 2020, we've been doing this treatment-based series that we've been producing as well. We've covered a lot of different topics. The final one is coming out next week. It is on surgery. We have a very unique perspective in this video with Dr. Mark Lewis, who will actually be on Lunch with the Experts in a couple of weeks, in March 18th or something like that. And he had the procedure himself, and he has that little diagram, and he explains it so visually and thoroughly, and it's very, very unique for this video. We're excited about that. I've just been working on it this week, so it's top of mind. So stay tuned for that. It'll be out next Friday. And for the other videos in that series, we cover carcinoid syndrome, PRRT, net guidelines. They're all under the videos tab. You can see them there. Okay, we've got.
Take this personal plug. Sorry. I think the world of Mark Lewis. He's like not just a gem of a human being, but also absolutely brilliant. So anybody who hasn't had the chance, and even if you had, you should definitely listen to him describe his experience. He's just, I think the world of the guy. He's amazing.
Could not agree more. I follow him, and we follow each other on Twitter now, and he's become a friend, and he's on the show, folks. I think the third week in March 18th, I believe. He's a great person, but this is a really unique story, and I have to give credit to Grace Goldstein at the foundation. It was her thought to bring him in the surgery video because he's not a surgeon, but he had this procedure, so it's a really unique perspective. Yeah, I totally agree, and plus one to what you said, Dr. Halperin, and he's just a gem of a person out there fighting the good fight. So, but enough of his praises. We'll keep
Sorry to digress. Yeah.
No, he's great. He's a friend of the foundation for sure. Edna says, if none of the labs point to nets and the mass is in the pancreas, the biopsy was inconclusive, would a gallium-68 scan be definitive for nets, or what might, if things aren't really pointing to that conclusively?
Yeah. So sorry, just to make sure I understood. So the question is, so none of the laboratory studies say it's neuroendocrine tumor. The biopsy is inconclusive. You kind of have, it sounds like, some imaging evidence that you think it might be a neuroendocrine tumor. And the question is then, will a dota tate scan of some sort, gallium, copper, what have you, tell you definitively? I wish the answer were yes, but it's not. We still hold pathology as the gold standard. Meaning some type of tissue specimen. That being said, we can draw some inferences if we combine sort of imaging over time. And so, we try not to encounter this situation, but we certainly have situations where, particularly something small, like if it's, 5, 6, 7 millimeters, and it sort of feels like no matter how many times the endoscopist tries, you get the best endoscopist in the hospital, and they still can't seem to get you a definitive tissue diagnosis. But it doesn't look anything like an aggressive, adenocarcinoma, conventional pancreas cancer, and you're following it over time, and the thing's not changing. We tend to think of that. That's probably what it is. You can't prove it, but we follow it like it is. But I mean, the gold standard is still the pathology. I wish these things had absolutes sometimes to make life easier for everyone.
Thanks for that. But to that point of regarding the copper scan, Lynn says, please educate us regarding the copper CU64 dota tate scan. Where is it available?
Oh, so To be honest with you, I actually don't entirely know. Full disclosure, I have done some work with that company also. So I've, but the way what I would say is, at this point, I think that, the data I've seen are that it's a perfectly good scan, as is the gallium-68 tate PET scan. They're both, they both seem to be really great in terms of giving you good pictures. There have been some data to suggest that there may be some finer resolution with the copper because of some of the nuclear details, but I'm not smart enough to say definitively whether I know to believe them or not. But I would say, if you're going to a center that's using gallium-68 dotatate, I think right now best evidence would suggest that that's perfectly fine. I think if you're dealing with an octreotide scan, that's a separate question. I think you should have some kind of dotatate PET imaging would be ideal. But I don't know enough to say if it needs to be copper, and honestly, if so, where it is. But I'm sure Curium's around somewhere and they can answer that question of where it's available for you.
So Kathy has a question also about the gallium-68 scan. So is PR ever done if the gallium-68 scan doesn't light up, doesn't indicate anything?
The current thinking is no, it should not.
How much does, and we might change the word here, I'm gonna let you do that, but David says, how much does the stage of a NET determine treatment? So I don't know if you would approach that as the grade, but I'll let you make that determination. But that's the question from David, and a couple of other people had that question as well.
Yeah. So that's a good question, actually, and I will start with stage, and then I can briefly do grade. And I know we're running short on time, but so stage, my answer is I actually don't talk about stage a lot with my patients. Because there's really only, as far as I'm concerned, there's really two stages. There's the stage where it can come out and the stage where it can't. And that's kind of it, right? So if it's, stage 1, 2, 3, where 3 means a lymph node that is distal enough, I'm thinking small bowel, lymph node distal enough that it's a chip shot and it can come out, it's coming out. If it's 3 where it's too far up the tree and it's sort of, right at the takeoff of the sphenomesenteric artery, and you're going to lose your gut if you cut it out, it's not coming out, right? But they're both 3, right? 4, if it's spread elsewhere, I mean, that also sort of is there's 4s where I ask my friends to operate, although it's not curative, and there's folks where I don't the stage 4 where I don't ask my friends to operate, or I ask them and they respectfully say no. I think about it less in terms of stage 1, 2, 3, 4, and more, can it come out or can it not? Actually, we wrote kind of a tongue-in-cheek editorial on a staging paper in JCO a couple of years ago that basically said exactly that. So great question, think the world of it. Grade, it depends. So, the easiest is poorly differentiated grade 3 versus well-differentiated grade 1, 2, right? Very, very different cancers with very, very different management. Where things get complicated is sort of that well-differentiated grade 3. And at present, there aren't enough data to really guide us about what to do there. And so, in the absence of data, opinions proliferate. And probably the smartest person I know who's thought about this more than anyone else is Dr. Emily Bergsland. And she very much, talks about, and I would never pretend to effectively summarize her words, but thinking about pulling from well-differentiated and poorly differentiated therapies as needed based on the overall clinical picture. And she's smart enough to do that. I'm not always smart enough to do that, but I think that's where sort of the grading makes things foggy, but at the extremes, it's really easy.
Got it. And speaking of Dr. Bergsland, she will also be on the show, everybody, March 25th, I think a month from today. Definitely a friend of the foundation. She's been in the treatment-based series that we released this year. Amazing doctor. So we're very grateful to have her on. So I agree with Dr. Halperin there. Okay, Rebecca had a question. Does sandostatin LAR stop or kill the cancer?
I think best we know, it does not kill. Very rarely, very, very rarely reduces volume. But it does slow the growth, sort of based on at least what we know about the cells, but also what we see in clinical trials. It slows the growth for real.
Got it.
Octreotide, lanreotide, similar data.
Okay. Laura says, once we have a dota scan, do we ever need another one?
That is a really good and difficult question.
What would if you do, or if you, what would determine if you did or if you didn't?
Yeah, so as I feel like sometimes I'm a broken record, but to me, the question with any test is, what am I going to do with the result, right? And how's it going to change what I'm going to do? So, the folks, we often say, like, everybody gets one up front to understand if the tumor has receptors or not. I think that after that, really, the SNM, the Society of Nuclear Medicine and Molecular Imaging, or SNMMI, has some nice appropriate use criteria. I know Dr. Hope worked hard on those several years ago. Very, very good. And honestly, the way I distill them to sort of a dumb medical oncologist is, if you have cancer you can't see any other way and you're thinking you need to see it change, then you might repeat a dotatate scan. So the most common one for me, especially folks with like thymic neuroendocrine tumors that's sort of home to the bones, and a lot of times you have a hard time telling what's going on, we'll use more frequent dotatate scans for those folks to understand if it's changing, because you might not see it as well on the other imaging. The other is if it's about to affect the therapy you're going to do. So, for example, thinking about the person who had a dotatate scan and maybe even had a dotatate scan 3, 4, 5 years ago, right? Because our folks stay with us for so long, has had several lines of therapy and now is progressing, and you're thinking about PRRT today, right? That's a situation where repeating it, right? It affects whether you can do this PRRT or whether you're just going to give the person sort of radioactive toxicity without benefit. I think it's important to know, and so we'll repeat the dotatate scan, but certainly not every month or two, and certainly not if it's not going to affect what you're doing. So if it changes your therapy or it's cancer you can't see any other way, then I'll tend to use them more frequently. And other folks do some different things, but that's how I think about it.
Got it. Gail says, after being treated for small cell cancer, chemo, and radiation, I've been told it's carcinoid by a pathologist. I have no flushing, no diarrhea, etc. Is there any other treatment other than octreotide? I haven't started it yet, and I'm being monitored by CTs.
Yeah. More common situation than you'd think, because as one of my other mentors, Dr. Yao, told me years ago, carcinoid cells are small too. And so they're just not as small as small cells. And so actually not as uncommon as you'd think to sort of get misdiagnosed. And it's actually kind of an easy sort of path thing to have happen. And hopefully you don't have any lingering toxicity from the therapy that you got. So we would think about that. I'm assuming we're talking about a lung neuroendocrine tumor, and there, we do think about somatostatin analogs. Everolimus has randomized data. People will sometimes use sort of gentler chemotherapy with temozolomide-based regimens. You'll find that in the guidelines. And then PRRT, even though the somatostatin receptor expression is a little bit more hit or miss with lung neuroendocrine tumors, probably more like half as opposed to 75, 80% for gut. That is something that we think about, although frankly there's very limited prospective and randomized data there because the rate of somatostatin receptor expression is so much lower. But those are things that we tend to think about. But I would, without knowing the specifics of the situation, usually we would start by leading with observation versus a somatostatin analog, which sounds like exactly what's going on, again, without knowing the details.
Of course. Dr. Halperin, you mentioned earlier, you said that you kind of sounded like a broken record. And I would say that I think, commonly used advice is generally that way because it's good. So I always like to ask at the end of the program, if someone is a newly diagnosed patient, and I know there's a lot of variables to consider, but what is the general advice you would offer to them in that first step of their journey to give themselves the best shot to have the best quality of life? Is there some general advice that you offer to new patients?
I think there's really two things that are really important, and honestly, it would all fall under the heading of sort of get the best education that you can. And so number one is find a pro, right? Because it's not necessarily, I'll be honest. I mean, most of my patients, it's not like they're getting their therapy with me, right? Texas is far from most people. And I would never hold myself out as the only expert around. There's plenty of folks you can see who do this all day, every day, and I have deep respect for all of them. But see someone who thinks about this a lot and can help guide you about the specifics of your situation. That's number one. Find a pro. Number two, find support. So, and again, no specific plug for CCF per se, although you guys are great. But there are many places to find support, and the community of sort of patients and caregivers here is so unique and rich and special that I think it's a great complement to sort of, you get the specifics from the pro and then a lot of the sort of broader educations from the support. And of course, everybody actually needs more support than you can get in a 15 or 20 or 30 or even 60-minute office visit, right? I wouldn't pretend, I wish I could give everyone sort of the level of attention that I know they deserve, right? But having a rich support network around you really helps augment it. And I think if you do those two things up front, you should be in the best possible shape.
Absolutely. I like that idea of the specific knowledge from the pro, but the support, the broader support from the community. I think that was beautifully put. One of my favorite things, as you all know, is this community, and in the show, it's embedded in the show, it's inherent in the show, and we saw that today. So I love that this show is not like a one-way webinar lecture, but it's an interactive conversation with the community. You all at home did a great job. And I mean this, like letting me know, hey, the audio is clipping out, like we're working together on this. It's a collaboration, it's a conversation. So I wanted to thank everybody at home for helping us with that today. Dr. Halperin, thank you so much, genuinely, for being here and rushing to get here. I know you have a lot on your plate, so I want to let you go, but I definitely want to thank you. We're going to send you some of the comments. Everybody else, let Dr. Halperin know how much you appreciate him being here too, and we'll send it to him in an email. Thank you, honestly.
Thanks, Bree.
Appreciate your time.
It's my absolute pleasure, and it's a privilege to be with you all. Thanks really for having me. Appreciate it.
Absolutely. And as always, thank you all at home for being here. We hope the program helped answer some of your questions. And reach out to Carcinoid Cancer Foundation either here on their Facebook page or their website, carcinoid.org. Thanks again to our presenting sponsor, Tracera Therapeutics. We could not do this program without them. As always, my name is Wayne Bennett. I am your host. Thank you for watching. Join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. Bye-bye.